Okay, so I'm going to be talking about midwifery and home birth in southern Appalachia, the oppression of midwifery and kind of the legalization of nurse midwives and the transition from a more holistic model to a more medical model, and some of the cultural components of that. So home birth currently, the legal status for North Carolina as of right now, certified nurse midwives can attend home births without a physician signing off on them. This changed about a year or so ago, so this is a big shift that we're kind of seeing. The hope for a lot of people who want a home birth would be that, okay, now this is legalized, we have a route that nurse midwives can go that's a little, they have a little more independence in it. But one of the nice things about nurse midwives working in hospitals is you have a call schedule. You're not the only provider on call for a specific patient. When you're practicing independently, a lot of midwives, it becomes really hard to have work-life balance, and there's a high rate of burnout because if you're at home with your family and you're getting called to a birth, you can't really travel. You have to schedule things kind of in a strategic way, and it can be really difficult. And when you're in a rural area where there aren't a lot of midwives practicing, you don't really have a good network of people to kind of split a call schedule with or have as a backup. So that work-life balance piece plays a role in people's decision of how they practice, where they practice. And then there's the fact that they're self-employed if they practice independently. And if you're a midwife working in a hospital and you have a steady income and you're able to support your family, you have benefits, there's just a lot of reasons why someone might choose to practice in that way. There's also a lot of fear about practicing in the home birth setting because a lot of people, it's like the modern witch hunt on holistic medicine. A lot of people aren't supportive of home birth. There's more risk of someone kind of investigating the work that you're doing. And in the state of North Carolina, certified professional midwives can't practice. Have you learned about the difference between CPMs and CNMs? I feel like I might have talked about it last time I was here. Okay, so certified professional midwives do an educational program through the North American Registry of Midwives. They can attend a MEAC accredited school, so MEAC is the Midwifery Education Accreditation Council, or they can do something called the PEP process, where they have a certain amount of the clinical requirements are the same for a MEAC accredited school as it is for the PEP process, but it removes the education portion. You don't attend a school. You are learning just from the midwife you're practicing under. And usually you have to practice under multiple midwives. You have to observe 10 births for phase 1. Phase 2, you're assisting. There's a certain amount of prenatal exams, postpartum exams, newborn exams, and then births. And then phase 3, you're the primary midwife, you're under supervision, but there's a certain amount of number for each of those categories. They have to see a certain amount of continuity of care where you're the sole provider for that person from their first prenatal all the way to the postpartum exams. Nurse midwifery is different. A nurse will go and get their RN and then usually their BSN, and then they do a master's in nurse midwifery. So they're getting all of this nursing education before they even get into the midwifery part, while a CPM is just learning about midwifery. So it's a little less medical. Nurse midwives can deliver a baby, they can prescribe birth control, they can do your pap smear. You can go to a nurse midwife for a lot of just basic reproductive health care needs, while an obstetrician, I kind of look at it as like a spectrum. We have CPMs on one end, where if you're a textbook birth, pregnancy, everything, you check all the boxes and everything has been normal, you might want a home birth, you might qualify for a home birth. If you're a little unsure of if that's right for you, you might move into a birth center or a hospital, and you might still want a midwife. And then when we get into more high risk, then we're having people deliver with an OB. And depending on the type of practice, family medicine doctors might also deliver babies. That's something that has been kind of new to me because in other areas I've lived, there aren't family medicine doctors that really practice in that way. But I'm in Ashe County, and in Jefferson we have a family medicine practice where that doctor has privilege to deliver babies at Ash Memorial. So people can go to that practice and receive care, and she will be on call for their birth. So there's kind of this like spectrum. We are one of the only countries that doesn't use the midwife's model of care as our standard of care. So typically a girl, might have irregular periods. The first period she gets, she's told she needs to go to an OBGYN practice. She's probably going to see an OB. She's probably going to be put on birth control. Like, this is kind of the routine that happens. Versus in other countries where for your basic care, you're seeing a nurse midwife. There's more appointments throughout pregnancy. They do well women care. The appointments are longer. The OBs are seeing people who are high risk. We're saving that level of care for the people who need that level of care. The midwife's model of care, the World Health Organization has reported that if everyone used that model of care, we would see an 84% reduction in maternal and infant mortality worldwide. Those longer appointments, the trust that you're building with your patients, you're connecting with them, they have more time to kind of open up about things they're experiencing. There's more postpartum appointments early on. We're just catching more things. 80% of maternal deaths are preventable. The U.S. has the highest maternal mortality rate of developed countries. It's 3 to 4 times higher for people of color. So we can see that there are these things that are very clearly preventable. And switching to a different model of care could really benefit a lot of people. But, that's not going to happen overnight. We have a lot of interesting laws, with home birth midwifery and CPMs practicing. And I say home birth, but I lived in Vermont for a while and was on the New Hampshire border. And in New Hampshire, in birth centers, midwives can practice CPMs can practice in birth centers. CNMs can practice nationwide. CPMs can only practice in about 38 states currently. Some states, there's no licensing process for them, so it's just considered illegal. So if they get caught delivering a baby, it's a felony. So then we're kind of seeing, okay, well, there's midwives who practice illegally. We have that here in Boone. Who are those providers going to be? Typically, they're going to be a higher income person. Typically, they're going to be a white person who feels comfortable practicing because the risk of getting arrested isn't as detrimental to their life as it is for someone who's from a marginalized community. This can be really problematic because midwifery comes from indigenous practices. The original midwives in the U.S. were in the South. They were enslaved women who were delivering white babies and black babies. And that switch to the nurse midwife model kind of happened in a way where Dr. Marion Sims was, the father of modern gynecology. He was experimenting on enslaved women. He didn't believe that they needed anesthesia because he believed that black people couldn't feel pain, that their skin was thicker, that they didn't feel it. So they didn't need anesthesia. He caused a lot of harm. No, you're good. And there was kind of this medicalization of birth where some of these practices, these more holistic traditional practices like midwifery, got pushed out the door. In Kentucky, Frontier Nursing, that was one of the first CNM programs. The person who created that program refused to hire black midwives. The nurse midwife program, we're one of the only countries that really splits the two into these separate categories of CPMs and CNMs. And it was done in an attempt to make it really hard for black people to get licensed because we're seeing that shift where they're no longer enslaved. They're trying to find a career route. They're not financially independent. Women in that time did not have financial independence. They were relying on their husband. So there was this push for higher income white women to be nurse midwives and to push black people out of the birth room. Specifically in the Appalachian region, I feel, and I hope that you'll agree by the end of this, that we can really benefit from more community-based care and more midwives because we have so many people who are really isolated, living up on a mountain, an hour from a hospital, and getting to a hospital is really difficult for them. But if we had providers that are in their community and they can have a home birth and they're not trying to rush to a hospital that's far away, One, it reduces the workload on people in a hospital. We know that every medical center is understaffed, overworked, and it contributes to burnout. So if we're seeing more care in the community, it reduces the workload here. It gives more options where people feel empowered and like they have autonomy over their birth experience. It connects back to kind of the culture in Appalachia of holistic and folk medicine. Community-based care is really big here. So yeah, that's kind of my introduction to midwifery. I want to pause to see if anybody has any questions. Yes.
What is the term lay midwife refer to? Is that the CPN model, or is that is that more like referring to people that have done it kind of not through a structured organization?
That's more of the non-structured. So sometimes people use the term traditional midwifery, and when I am using like traditional or sometimes they're referred to as like granny women. In Appalachia, we refer to them as granny women. They were the people who grew up around birth, and we still see it like in the Amish community, where there are women who attended all the births in the community because they were related to people, and it was just like, oh, I'm a teenager and my mom's giving birth, I'm supposed to be there to support her. Oh, my cousin's giving birth, now I'm going to be there. And it just kind of was the normal for them. So those are more of the like lay midwife. And then there's also some people, this is where it gets kind of like, I want this to be a really open discussion about like some of the concerns that people have with home birth, because there are concerns to be had. There are people who grew up in kind of that traditional holistic medicine, and they're birth keepers. So, or they refer to themselves as birth keepers, and they have no formal training or education. Their training is completely lived experience and what they've, maybe like an apprenticeship they've gone through or something like that. But they are not there to deliver the baby, but to like hold space. It's kind of this like in between of the lay midwife and a doula, where they're just there to support. And in some cases that works out beautifully. You know, there are a lot of instances where like you could be in the room with someone who's delivering and you could just sit in the corner and you probably don't need to do anything. It's going to go fine. They're going to do skin to skin after. Baby's going to warm right up. They're going to breastfeed. That's going to get oxytocin flowing to help with the uterine contraction. So we don't need to use Pitocin. Like there's all of these things that we can do to encourage a natural birth, and it can go wonderfully. But if someone isn't receiving any prenatal care and they make that choice, there's a lot that we might be missing. So that experience of having a birth keeper might not go well for them, which is why I think whether you support that or not, I think that we need providers to be more open to home birth, so that if someone wants to receive prenatal care, because of the access to midwifery and the way that care is kind of happening in the high country, we have one home birth midwife, and the care that she provides prenatally isn't the same as the care a midwife's going to provide in a state where CPMs can legally practice. She has to be very careful about how she practices. So if somebody could go to their family medicine doctor or go to a nurse midwife for their prenatal care and have that open discussion of, hey, I'm going to be honest, I really want a home birth, and it can be really open and trust that their provider's going to let them know, like, you have preeclampsia, you should probably not have a home birth. Like, we need to talk about this and come up with a plan that makes sense. And have that open discussion of like, I understand you don't want to give birth in the hospital. This is the safest option for you and your baby. How can we make this experience closer to kind of what you're looking for? Can we get you in a room where there's a tub so you can labor in the water? And just kind of like having those discussions. I know a lot of people get really turned off by people creating birth plans. But the way I look at it is like, if you're planning anything in your life or like getting ready to do anything in your life, you probably come up with a plan. And the plan is there to kind of give you some foundation to stand on of like, okay, here's kind of how I want it to go. And then we adjust when things don't go as planned. Like, I just installed a gate on my property. I didn't just wake up one day and like put together the gate. I had a plan of like, I need these materials and this is kind of how I imagine this going. And if it didn't go as planned, I adjusted, but it kind of gave me that outline of like, here's how I think this is going to go. So I kind of look at a birth plan as that, like, this is how we hope it's going to go. These are the things that this person's open to. Obviously, once they're in labor, like someone might say they want to labor in the tub, then they could be like, this is awful, get me out of here. And we adjust. So just having those open discussions of like, here are the supports that we have in the hospital. Do you want to have a doula because you can't have a home birth? Like, how can we kind of come up with something that's a happy medium? And I think that trust is a big piece, because a lot of people don't trust the medical system. So if their provider says like, hey, I don't think that you should have a home birth, they might go home and be like, screw the medical system. Like, they're always telling me I'm wrong and they don't support me, and they might choose to have a home birth anyways. So just having that trust and like those open conversations. And I think because CPMs can't legally practice here, there's also a lot of fear that like, if I'm open with the medical provider I'm seeing at my like tradition, like my modern medical practice, if I'm open with them about the fact that I'm gonna have a home birth, can I actually trust them with this information, or are they gonna like ask certain questions just to find out who my midwife is to get her arrested? Like, and most midwives who are doing home births, they know the warning signs of when something's going wrong, and they want to transfer to the hospital if something goes wrong. If it's out of their scope, they want to do that transfer as early as possible. Nobody wants to experience a patient dying or like a baby dying. Nobody wants that. So if there's that fear of like, well, if I transfer my patient, am I going to get arrested? Like, is the focus going to switch off of my patient and just be on the fact that like I'm a midwife? Like, how can we do this? So I think that, obviously there's certain things that we have to report, and there's like things that we have to follow, regulations that we have to follow, especially if you're in a medical institution. But how can you build that trust and make sure your client is, or your patient is open with you? And then I think we do have a lot of people here who they're not concerned about home birth. They're happy to deliver in the hospital, but they grew up in the Appalachian culture, and part of that is the holistic medicine and being really connected with the land. So there are some like folk medicine practices and spiritual beliefs and superstitions that a lot of people in Southern Appalachia have. Birth is typically seen as a really spiritual and communal event. The culture here was heavily influenced by European, African, and indigenous traditions. Some superstitions that exist, pregnant women need to avoid graveyards because it's bad luck. Something can go wrong with their pregnancy. Some people will place a knife under the bed when they're in labor because it symbolizes cutting the labor pains. Some people will hang an iron key near the bed to ward off evil spirits. Some people will use herbal remedies like raspberry leaf tea for uterine health, ginger tea for labor pains, peppermint essential oil for headaches. And being kind of aware of what some of these things are can be important in your practice, because peppermint helps with headaches and nausea, but it can also interfere with lactation. So if someone's going to use peppermint throughout their labor, once they're getting close to like 7-8 centimeters, we might want to be like, okay, let's try something else to help with the nausea and headaches. Let's get rid of the peppermint because this is going to start to impact your milk supply. Elderberry for immune support. People might use different herbs to induce labor, so being educated on that can be important, so you can provide evidence-based information on the safety and efficacy of it. This is also, incredibly important when we're working with people who have had complicated pregnancies in the past, that have had, like if they're at risk of preterm labor, they might want to avoid certain herbs and certain essential oils and things that might induce labor. They might not be the best candidate for that kind of natural remedy. So yeah, community midwives, they were known as the granny women. They provided prenatal, birth, and postpartum care. Again, a lot of the knowledge was passed down through apprenticeships and not formal education. They used herbs, prayer, and hands-on techniques to aid in birth. They were seen as both healthcare providers, but also spiritual guides. They were often community leaders and assisted with other healing needs beyond childbirth. So that's the traditional kind of folk medicine, holistic midwifery model. And that comes up a lot in the professional midwifery education. They learn a lot about the use of herbs. If they go through a MEEC accredited school, that's a big part of it. They're also educated a lot on lactation. It's not necessarily just delivering babies that the professional midwives are focused on, but it is a little less than what a nurse midwife does, where a nurse midwife can do more like prescribing of birth control. Like CPMs can't prescribe medication. Depending on the state that they're in, that'll determine what their scope is. Like CPMs in Maine, they're responsible for newborn care and the first 8 weeks of medical appointments for the newborn before that newborn goes to a pediatrician. While in states like Vermont, the midwife does like one newborn exam and then the newborn is under the care of a pediatrician. So it differs so much state to state, which is good in some ways because we can have, those cultural components kind of influence it, but the culture differs so much across the state of North Carolina that then it gets kind of confusing. If the care that a CPM can provide differs so much state to state and there's not a standard scope, it creates a lot of confusion, a lot of myths and misunderstandings of like what a midwife is and what they do, and it can just get a little bit messy. Any questions about any of that?
They still recommend like prenatal care with an OB or like a nurse midwife or a FMOB, whoever, just to make sure the pregnancy is like going well, or is it just kind of patient dependent?
Usually they're just seeing a CPM. I think that in our community we see more of a combination of care, where if someone's using a CPM, they may also still be seeing their provider because CPMs are illegal here. So the amount of care that the CPMs in our community feel comfortable providing is limited, versus if we were to legalize CPMs, then somebody would go to a CPM for all of their care.
Okay.
And the CPM would assess in that first appointment, like, oh, are you pregnant with twins?
Mm-hmm.
Sorry, you need to go to it. Like, let's make a referral.
Would they still do like the glucose testing and the lab work to make sure they're not like anemic and things like that?
Yeah,
Oh,
so they
okay.
would run those kinds of tests. They can't prescribe medication, but like when I was in Vermont, what is it called? Rogam? Is that the term? Like we would make runs to the hospital all the time to go pick that up if we needed it. Like that level of care was still provided. We have oxygen tanks. We have all the resuscitation equipment. There was a case where there's a home birth in New Hampshire, and one of the midwives I used to work with was attending, and we have to have even if you're just a midwife's assistant, you have to have your neonatal resuscitation certification. Like we have to be up to date on all of that. But there was a midwife who called 911 because there were complications, baby needed to be resuscitated, and the paramedics didn't even know how to resuscitate a newborn. So she was like, can I just do it? Like the laws state, regulations and like our codes state I needed to call 911, but like I'm the only one here that's actually trained in this. The paramedic isn't even trained in it. So when we legalize CPMs, the way that they can practice is safe. There are these codes of like, and it differs state to state. Like in Massachusetts, there are providers who will deliver a breech baby at home. South Carolina, no breech birth, no home twin births. In New Hampshire, you can deliver twins at home or in a hospital, like with a doctor. The CPM can deliver at home, but CPMs cannot deliver twins in a birth center. There's all these weird little rules, but they put those regulations in place to weed out people who should not be having a home birth where it's not safe, and to keep the care that a CPM is practicing within their scope. So if somebody has like preeclampsia, or if they have a history of having babies who are jaundiced, they're probably going to be referred to a different provider and they're not going to have a home birth. They may qualify for a birth center birth. And when I say birth center, I mean freestanding birth center, not connected to a hospital. A lot of them are strategically placed near a hospital because there's some reasons people might choose a birth center birth over a home birth. Maybe they want that natural experience. They want to feel like they're at home. It's interesting because the birth centers typically send people home after like 2 hours. So you have your baby, 2 hours later you're back in the car, you're going home. If you deliver late at night, they might let you stay the night. you're in a room where you have like a birth tub, a bed to deliver in. It feels very homey, but people might choose that because their insurance only covers a birth center. Some states, Medicaid doesn't cover home birth, so someone, for financial reasons, might choose a birth center. Maybe they live in an apartment, or they have a lot of animals at home, or they have other children, and they're going to have a babysitter in their home, but they want to be somewhere like where their focus is just on giving birth. Maybe they do live in a rural area, and they want a home birth, but they are nervous about if they have to be transferred to a hospital. Well, then they can deliver at a birth center that was strategically placed near a hospital, because a lot of people who open birth centers will have them really close to a hospital in case they need to transfer. So the legal and regulatory barriers limit the way that midwifery is practiced. We have a lot of maternity care deserts, especially like Allegheny County. That's a maternity care desert. We didn't even have a single doula in Allegheny, which I'm trying to change. But the access to like any maternal care of any kind is so limited there. And it's very unlikely that like a hospital is going to open out there that has a maternity ward. I mean, when I was in Vermont, I started to see it. Big hospitals were buying out the smaller hospitals. We saw that with Watauga being bought out. But one of the first things to go is the maternity ward. If they don't think that it's bringing in enough money, it's going to be cut. But then in states like Vermont, it's similar to the community that we live in Western North Carolina. You could be an hour from a hospital, and we have bad winters where the roads are icy and it can be dangerous to be driving. And if it's a case where it's like a single mom, do we really want her driving while she's in labor, like on icy roads to the hospital? And these sometimes feel like, oh, well, like what are the odds of that happening? How often does that happen? But it happens. Like we saw it during the hurricane, tons of reports of unexpected home births in Asheville. Like stuff happens. And if we have more care in the community and we do it in a way that works, and when I say works, I mean like financially we're not going to open a bunch of like maternity care centers all over rural areas. It's just not going to happen. There's not going to be funding put towards that. It's not going to be deemed as necessary. But if we have more community-based providers and we legalize midwifery care, there are other options for people who are in those really rural areas. We still see really high disparities in maternal health care for Black Appalachian women. I know that the area that we live in is not super diverse, but we still see those disparities for people of color in our community. With the laws and barriers that we have, it limits insurance coverage for home birth and midwifery care. And then there's also like the lack of understanding within the medical system and the insurance system. A lot of insurance, if you call your insurance and ask about a home birth, your insurance might not even know if they cover that. Like it's just not something that's talked about a lot. The more we talk about it and kind of voice concerns with the safety of it and who qualifies for home birth, the more we're gonna have better systems in place to support people who want that and be able to kind of create just conversations around like what should those regulations be if we were to legalize CPMs in North Carolina, and what does that look like for our community specifically. With the lack of access to CPMs here because of laws and the way that CPMs are regulated across America, we're seeing a shortage in midwifery education programs because a lot of people aren't seeing it as a route that they should go if they might not be able to practice, because there's that risk of like, well, I currently live in a state where I can practice, but what if I move or something happens and things change? Which means a lot of people are relying more on those apprenticeships and being like a lay midwife instead of going to a more formal education program. And we see this with like CNMs too. I mean, there aren't a lot of CNM programs, so that doesn't really feel like a super possible like career route for a lot of people. And then the increased medicalization of childbirth leads to fewer home birth options. There's limited research on home birth, but some research does show that there's lower rates of maternal interventions, decreased maternal morbidity, increased maternal satisfaction, continuous labor support reduces stress and anxiety, and people report better birth outcomes, better perceived outcomes. There's more support for physiological birth, but then there is the risk of delayed emergency care, and there's inconsistent neonatal outcomes. But the research on home birth isn't something that a lot of researchers aren't prioritizing this, so there's limited data. And then a huge concern is just the professional opposition. A lot of people are just so against home birth that, again, there's not research being done and there's not really discussions about this. So some of the things that we can do is kind of try to bridge the gap between traditional midwifery and clinical healthcare, encourage collaboration between midwives and medical professionals, advocate for policy change, advocate for culturally competent care to preserve some of the Appalachian birth traditions, more training programs on what that looks like, and better referral systems between midwives and hospitals. It's 1 now, so I don't want to keep you guys too long. So the reflection questions just to think about are: what challenges do healthcare providers face when trying to implement culturally competent care in rural communities? How can you build trust with your patients who have a historical mistrust of institutionalized medicine? What are some ways that traditional Appalachian birth practices can be integrated into your healthcare system? How can U.S. practitioners support home birth while ensuring patient safety? And how can you address the shortage of maternity care providers while respecting cultural traditions? And I will stop there. Any questions before I head out?
Can you send us your PowerPoint?
Yeah.